Be here. I'm so excited to be here to chat, as always, chat some medicine, learn new things. I am super sad that Jack unfortunately couldn't join us today. He'll be here in the spirit, and I'll do my very best to channel my Jack Penner wisdom. Although I don't know if I can do as good of a job, but we'll have a good time. And feel free to, as always, like put your thoughts in the chat. And if you're in a place that, thanks, Robbie, I appreciate you. And if you're in a place to share your thoughts, I'll just ask to unmute so we can all have a discussion because I definitely will need your help. I think Madalena has a case. I'm super excited to learn from you. Madalena, do you want to say hi? And then maybe we can rock and roll?
Yes, hello everyone. Good morning. It's 8 a.m. in California, so I can't think of a better way to start the day than learning with you all and discussing the case. So just happy to be here and excited to see you all.
Yeah, I couldn't agree with you more. I have my VMR crew and I have my coffee.
Yeah,
it's already a great start to this.
Me too.
And thank you so much, Ravi, for scribing, and thank you so much, Yasmin, for doing teaching points today. If we can get the board up, we'll get started. Thank you so much, Ravi. All right, Madalena, mic is yours.
All right. Okay, so the chief concern is actually two, is acute onset nausea and abdominal pain. And I'll give you a little bit of information about the patient. So this is a 74-year-old woman who is presenting to the emergency department with acute onset nausea and this diffuse abdominal pain. So she describes that the abdominal pain and the nausea were both rapid, kind of spontaneous, and just an unprompted onset of diffuse abdominal pain that started a few hours prior to admission. So she says that since it started about 2 to 3 hours ago, the pain has been constant, non-radiating. She just describes it kind of diffuse in nature. And when you ask her to rate it on a scale of 1 to 10, 10 being the worst pain she can imagine, 1 being no pain, she rates it as a 10 out of 10. So I will pause there to get some initial thoughts.
What a start, Madalena. Thank you so much. So what we have here is a 74-year-old woman who's coming in with like acute onset nausea and diffuse abdominal pain. And whenever we see two chief complaints, the question is, which one do you want to frame your thinking around, nausea or here abdominal pain? Are they truly related or not related? Most often, nausea and abdominal pain tends to be related. Sometimes causes of nausea can be central causes, from a vertigo to anything else. However, in this case, if you want to build a differential, how I want to think about it is like, which one is like more urgent for me to figure out? And that's abdominal pain. And when it comes to abdominal pain, belly, a lot of important real estate in there. So the differentials tend to be really, really big. Yet I feel like though my initial framing is always, my no misdiagnosis, thinking about, and I like the mnemonic VIPO. So it's for vascular. So vascular, kind of thinking about not just gut ischemia, but also what is the neighbor of the abdomen. You have the thorax. You have these are your diaphragmic issues and also your cardiac issues. So like inferior MIs can sometimes present with abdominal pain. An elderly person with acute onset nausea and abdominal pain, we really, really need to make sure this patient is not having an anginal equivalent, and this is not an MI that is presenting an abdominal pain. And then to think about I is like your itises, so inflammation in your cholecystitis, your appendicitis, like infection that is presenting with that. The next two, perforation and obstruction, are the things that, as an internist, I might not see all the time, especially the initial presentations. But however, if you're seeing the patient in the emergency room, really good to think about perforation and obstruction, small bowel, large bowel obstruction, especially if that nausea is sudden, she can't get a whole, keep anything down. And if she has any history of surgeries in the past, especially abdominal, that cause adhesions. Obstruction should something for us to think about. And the addition to the viper that I like to in a woman, especially younger woman, would be like something like an ectopic pregnancy, anything in the pelvic floor. However, like 74 is a bit old for that. So that is how I kind of like frame myself. I think about like your my misdiagnosis first until we get some additional information and think about different quadrants and where that is. And then the last thing is like, don't forget about the neighbors of the abdomen, which is like your pelvic, your urinary system. So, your, retention, acute retention really hurts the belly. Kidney issues can really hurt the belly as well as what's going on in the thorax. So I'm excited to learn more.
That was just beautiful. I loved kind of the structured approach to acute abdominal pain and what other questions you'd want to know. Okay, so I'll answer some of the questions you asked and also some of the questions that came up in the chat. So you asked a little bit more history, has this happened before? And she says that really for 2 days, she's had this intermittent abdominal pain and distension that really just became very intense a few hours prior to admission. She specifically recalls, the day prior to admission, a brief episode of similar, really intense discomfort, but then it resolved spontaneously. You ask when her last bowel movement was. She said that she last had a bowel movement 3 days ago, and you ask if she has passed gas. She doesn't believe she's passed any gas. On review of systems, so she's describing this really intense nausea. She said that she's had 2 episodes of vomiting since this really intense pain started a few hours ago. This abdominal distension she's noticing, and also just some dizziness, chills, and just overall not feeling well. She hasn't had any diarrhea, no fever, no other systemic, no like joint pain or chest pain specifically. Let's see, I want to make sure okay, great. So I'll fill in kind of the rest of this corner here. So for the past medical history, she says that she does have a history of constipation that's been going on for many years, no other medical conditions. Past surgical history, she has a history of uterine fibroids, status post myomectomy. She's also had 2 DNCs. Family history, non-contributory. What else we have? Social history, does not use alcohol, tobacco, or any drug use. No other relevant social history here. She does not list any medications that she takes and no supplements as well. So Charmaine, did you want to comment on this, or do you want me to give you the physical exam?
No, this is a great place to start. Thank you so much, Magdalena. And everyone's, I love the thoughtful comments in the chat. I think Volvulus is getting a shout out, which I absolutely think is a good thing to think about in this case as well. I think Ravi asked about cannabis use, given like the episodic abdominal pain that she was having initially. I think that's a fantastic thought. Priyanka asking about trauma. I think that is also another fantastic thought. And thinking about like endometrial malignancies, large fibroids can cause obstruction as well. Yeah, absolutely. Keep all the amazing thoughts are coming. Thank you, team. So now we're getting a background of like maybe this abdominal pain has been going on for a little while before it got constant. So it sounded like she had like a little bit of intermittent episodic abdominal pain and distension, and then it became constant at some point. So what to do with that information? Is that kind of the beginning of her pathology, or that was something else and we're dealing with something different now? With the things that are episodic, one thing that I try to remember that be careful when you're evaluating something that is episodic in general. Now she's having a constant abdominal pain, but with episodic, your exam can be falsely normal if the patient at that time is not having the pain. And, sometimes with abdominal pathologies that are episodic, your imaging might not capture that. So remember that when you're weighing the value of the imaging or exam as you're going through it. And with the distension, with distension, the question is like, why is the abdominal distension? Is it filled with gas, liquid, or solid? 2 days is a long time for a solid to develop. So is this gas that is backing up, or is this like a new onset ascites that we have to think about at our exam? And more lab work would be really informative in that. The two episodes of vomiting going hand in hand with like nausea and abdominal pain, not too surprising. It just kind of tells us the story of how severe this is and that we should get to the bottom of it. And I'm really, really glad she's taking care at this point, because again, if you can't take PO intakes, we will have to think about like rehydrating this patient until we figure out what is going on. The fact that she doesn't have any diarrhea, fever, joint pain, chest pain, yeah, I think abdominal pain is broad enough that none of that makes it any causes more or less likely, and especially in the elderly patients, sometimes like they don't present inflamed. I have seen like acute cholecystitis present with just tachycardia and nothing else at all. So I caution in terms of like dismissing anything because there's no fever involved. The past history of constipation is actually really informative. Just like, acute urinary retention causes severe abdominal pain, I have seen like older folks present with altered mental status, really diffuse abdominal pain just because they're severely constipated. So it would be helpful to know when this patient's last bowel movement was. And if you're just dealing with really large stool burden, can become sterocolitis that can lead to perforation. So constipation, not benign. So that's really, really helpful to know in terms of past medical history. The social history in terms of like the fibroids doesn't sound like she had any like intra-abdominal procedure for that. So again, like thinking about like adhesions possibly, nothing there, and like health related behavior is always like good to know, especially with tobacco and the risk of cancer. So where are we now? I think we're still firmly in our acute abdominal pain. The fact that it was episodic, informative. However, I'm more inclined to kind of just think about this as a acute abdominal pain. Make sure to rule out our no misdiagnoses and go from there. I'm excited to see what the exam shows.
All right, okay, jumping to the exam. So the vitals, the temperature was 98.5 degrees Fahrenheit, heart rate was 88, blood pressure 150/78, respiratory rate 16, and she was satting 98% on room air. So in general, she's fully alert and oriented. She's conversational, but she appears in acute distress and also appears somewhat fatigued. HEENT exam, normal oral mucosa. Cardiovascular exam was unremarkable. There was a normal S1, S2, no murmurs. Pulmonary exam was also unremarkable. The lungs were clear to auscultation bilaterally. So the abdominal exam, so there was diffuse abdominal tenderness to palpation. There was no overlying erythema, no rebound tenderness or guarding. There was kind of an area of a more focal swelling in the left lower quadrant that was soft. As I said, no rebound tenderness or guarding. And the neuro exam was unremarkable, and extremities, 2+ radial pulses, no rashes, no ecchymoses, nothing notable on the extremities. And so I can give you the initial labs as well. So for the white blood cell count, that was 10.3. The hemoglobin was 12.7. The platelets were 160,000. The sodium was 137, potassium 3.8, chloride 100, bicarb 26, BUN 19, creatinine 0.56, and the glucose was 221. A lactate was also obtained, which was 1.4. So I'll pause there.
All right, keeps getting more interesting, Madalena. So, starting with the vital signs, if patient is afebrile, not tachycardic with a heart rate of 88, and she's not taking any medications. So, whenever I expect a tachycardia, I just look over to make sure this patient is not taking any beta blockers. But no, she's not tachycardic. Her blood pressure is a little bit, on the higher side. I wonder if that's, the pain contributing to that. I think someone and Nikita asked for baseline blood pressure. Always good to know where the patients are, especially if they're in your system. Sometimes, like, what if this patient just doesn't engage with care and her blood pressure was always like in the 200s and now she's presenting with 150? That's relatively hypotensive for this patient. Or if this patient is always like in the 80s or 90s and now presenting with 150s, again, with blood pressure, you really want to think about the delta of that. But it seems like, at least of the vital signs, the patient is stable. I'm really, really glad that the person performing this exam took the time to definitely listen to the basis of the lung and also think about the cardiac and what to do with that abdominal exam. Diffuse tenderness, maybe some swelling the left lower quadrant. So the question becomes like, what does that swelling represent? Is that fluids? Is that a bowel that might be obstructed and kind of presents itself as kind of a swelling of that region? To think about whatever like diverticuli during that in that space. Occupies it. Again, swelling is a little odd. The other thing to think about is like abdominal wall hernias. That again, the left lower quadrant would be an odd place for that, especially if they didn't have any surgeries there in the past that disturbed like the soft tissue. However, that's another thing to think about in terms of skin findings. Again, thinking about like sub-Q abscesses, anything else would be odd place for it. But now what I'm trying to do is that I'm knowing that I need to look in the belly, but also not forgetting about the skin and the soft tissues and what else that could happen there. Because you don't want to get a CT that shows something that we should have picked up on the exam. Normally, it has happened. But good practice to kind of think about other things as well. However, I'm still thinking about this as like kind of the diffuse abdominal pain with the question of like what that left lower quadrant swelling is presenting. The fact that the pulses are good and strong, because I saw a lot of thoughts on for a mesenteric ischemia, which I think is a good thought. And thinking about if this patient has any signs of like peripheral vascular disease would be helpful. In terms of like the basic labs, the white count of 10, usually like a little on the higher side, but within normal limits. Nothing really jumps out on labs. To be honest, the only thing I was like really listening for was the electrolytes and also the creatinine, just so I can like scan this person. Again, the labs are normal, the patient's vital sign normal, but the patient is still in such discomfort. She had nausea. Remember, she was vomiting for a couple of days. I am scanning her belly. I'm like getting a CT abdomen pelvis. The first thing before I do that, I would get a troponin and I would get an ECG. And I'm looking for a couple of things here because we don't have like instead of constipation, we don't know much about her cardiac history. If she has like prior history of Q waves, like on her ECGs, I'm trying to get a sense of like does this patient have any risk of atherosclerotic disease? That now she can have that in her belly as well. And also looking for MIs as before. So I would get the ECG next, get a troponin. I would also get image her abdomen and also put and just do bladder scan and a PVR to see if there's any problem with retention there. Again, the belly and the neighbors of the belly. And yeah, and just to see what all of you amazing folks thinks. Oh, Robbie, the calcium is a great thought. I don't know if Madalena, you have that. So thinking about electrolytes, I usually think about like, what in the bowel especially are full of muscles. So what requires muscles to work is your calciums, your potassiums. So those electrolyte abnormalities can definitely cause issues. I love that thought. Thank you for bringing it up. All right. Oh, with calcium within normal. Awesome, Madalena. All right, team. Thanks so much for all the amazing thoughts. Madalena, back to you.
Okay, really phenomenal discussion so far, and I love all the thoughts that have been brought up in the chat. So the EKG showed normal sinus rhythm. I don't have a troponin for you, but what I do have is we did get imaging of the belly. We got a CT scan, and I can actually share my screen. I just took like a screenshot of one of the more interesting shots of it. So let me go ahead and share my. Okay, I'll just stop the other person's screen sharing. Okay, can you all see this?
Oof.
Okay, so this was an image that I just took of the CT scan that was showed. So I'll let you all kind of give your initial interpretations, and then I can show what the final read was of that.
Oof. So this patient came in with distension, and we talked about whether it could be fluid, it could be gas or solids. And this is a lot of gas. So incredibly distended bowels. And there's like, I think like some stool burden there. But I'm excited to hear about what I think the things to ask, is there any transition points I would want to know, the radiologist to know, to tell us, and then go from there.
Okay, great. So I will stop screen sharing. Okay, so this is the CT scan of the abdomen and pelvis, and the way the radiologist read it was a colonic volvulus, actually. So they described it as possibly transverse colonic volvulus with transition point in the mid-abdomen, proximal to the splenic flexure. Colonic wall thickening in the transverse colon concerning for ischemic colitis. So that was kind of the main diagnosis here from the CT scan. So the kind of the final diagnosis was really like a large bowel obstruction due to this transverse colon volvulus. And I can talk a little bit about kind of what the next steps were surgically, but I just wanted to pause to hear any reactions to that.
Wow. Yeah. What a case. You know, I kind of think about like kind of doing a cognitive autopsy. So it kind of sounds like colonic volvulus caused obstruction and caused retention of air that led to the nausea and the vomiting. And probably that episodic nature of it was like, it's probably an acquired thing that happened. And she was like having this like episodic nature of the pain, and then it became constant when the bowel was just like, kind of like, if you think about it, it's just like decreasing its own blood supplies and leading to ischemia. The other to think about, like, I would love to hear from that. I don't know, what are your thoughts about like why this happened, and what did you guys did for it? Why this is such a great case. I love bread and butter medicine and thinking through like abdominal pain and nausea, the things we see all the time. So I'm really, really grateful that you presented this case. I'm excited to learn from you.
Yeah, no, this is also fascinating to me. I actually saw this on my surgery rotation, so I'll go a little bit more into the kind of what happened afterwards. So an NG tube was initially placed, and that drained 300 cc's of bilious fluid. So she was scheduled to go to the OR for an exploratory laparotomy. Shortly before transfer to the OR, she actually became hypotensive to the 60s over 40s, but responded to resuscitating measures. So in the OR, there were actually a few surgeries, but the first one, the large bowel was found to be severely dilated and necrotic from the cecum to the splenic flexure with an abrupt transition point. So they did an extended right hemicolectomy, and there was no evidence of perforation. The bowel was actually left in discontinuity. So then she was transferred to the SICU, where I actually met this patient. And then there was a follow-up surgery where they did an anastomosis between the ileum and the colon, and then closed the closure of the abdominal wall. One thing that was really interesting to me on this case is, so pre-op, the lactate was 1.4. But post-op, the lactate was actually measured to be 7.2. And that was just like, that really like significant increase stood out to me. And I done a little bit of thinking about that and talked to some of like the surgeons on this on that rotation with me, but I wanted to hear if the Chad or Charmaine, if you had any thoughts about like what could have explained that really drastic increase.
As you were talking, I was getting tachycardic, Madalena, because just kind of makes you appreciate just how this really, really bad, your no misdiagnosis of abdominal can initially present on imaging and on vitals and on exam not that infant, right? If the
Yeah.
lactate was normal, she wasn't tachycardic, she wasn't hypotensive. And yet, again, like thinking about the clinical presentations, like this abdominal pain was really, really worrisome. So I'm like glad she got like a very thorough workup. In terms of the lactate, I'm really, really curious, but just kind of thinking out loud with you, a lactate that was normal, then it became elevated. Sometimes when you get, you have some ischemia and you have reperfusion, then, that area that was like necrotic and has like lactate built up and no blood supplies to bring it into the rest of the blood system, I would assume that that can cause like transient elevation. If there was and during a procedure, if she became hypotensive and she has some underlying ischemia to begin with, any vessel atherosclerosis that the gut became more ischemic, that can cause an elevated lactate afterwards, especially if that relates to a really tough case or hypotension, or thinking about kind of the drugs that the patient was given during anesthesia. Is there any of them cause like lactic acidosis to begin with? The other one that I always think about, like meds, she was taking on any medications, but like meds like metformin in people who are septic can cause type B lactic acidosis. So kind of like thinking about those few things, but I'm excited to learn from you.
Yeah, no, and I think given her clinical course, there are kind of a lot of reasons that could explain the elevated lactate. I think when on the surgery rotation, when I was asking about this, so as you said, this intermittent pain was thought to be kind of the twisting and then untwisting of this volvulus that had occurred the few days leading up to this initial presentation, when it, I guess, twisted and then just didn't untwist. So the thought was that potentially, when it twisted, there was like ischemic bowel that developed, but potentially the lactate didn't make its way to kind of the systemic circulation because the vasculature was twisted on itself and compromised, and not until in the OR where they were able to untwist it was like kind of the lactate from the ischemic bowel released into the systemic circulation. So that was one thought that came up, which was just really interesting to me. And the surgeon I was talking to said that wasn't uncommon. Sometimes you don't pick up the elevated lactate initially because it's like contained within that twisted bowel, but then when it's released, it gets released, which was just really interesting to me.
Kind of similar concept that if people have MIs and then you open up that vessel, they get a stent, you don't want to take a troponin afterwards because the troponin will be higher. It's the same concept.
Oh, interesting. Yeah.
You are reperfusing an area that wasn't getting perfusions, and then you just get a lot of the elevated trope. So yeah, kind of similar concept to that. That was amazing, Madalena.
Yeah.
Any other learning that you want to share?
No, I think people had talked a little bit about the different types of volvulus, and I think that just came up a lot earlier for me. So just that there's like three main types of volvulus that you can get. You can get kind of the cecal volvulus, you can get the sigmoid volvulus, and then even the midgut volvulus. And really the distribution of the different types are dependent on really kind of the age of patients. So a cecal volvulus is more common in generally younger females, and sigmoid volvulus you can think more in elderly folks, and constipation is a big risk factor for that. Those are some of just the main points that I took away from this case, and would love to hear the teaching points.
Thank you so much, Madalena. It's such a great learning case. Thank you so much for teaching us, sharing this with us, and you all are amazing in the chat. Thank you so much for all of the thoughtful discussions. Ravi, thank you for scribing. I really appreciate you. And I cannot wait to hear Deborah's teaching points.
Thank you, Madalena. It was a great case. Thank you, Charmaine. Yeah, going for this case, the patient presented with abdominal pain, and it's the first symptom that we need to take care. And we have the mnemonic vital that is for vascular I for inflammation, infection, perforation, and obstruction. And we need to take care in the case of this patient of an ectopic pregnancy, but even that it's kind of old, we need to have that in mind when we're a woman. We need to check the kidney too, and we talk about the baseline blood pressure because we need to know if that value is normally for the patient or if the patient is more hypotensive and then this is high. And then swelling, we thought about fluids, obstruction, diverticulitis, and abdominal hernia. And Charmaine said that we need to look for the ball, but don't forget the skin and the tissues. And this patient had everything normal, like in the lab, but we need to remember to check the troponin and the EKG and see if the patient has like a risk for atherosclerosis. And in the end, the patient presents the lactate, the pearl that I took that get higher, and that could be by the ischemia that the patient had an ischemia tissue and then had the reperfusion area, and that can cause a lactate elevation, and then some drugs can cause a lactate acidosis like metformin. So that's it. Thank you, everyone.
Boom! That was awesome. Thanks, Deborah. Thanks all for joining us. Can't think of a better way to start my Wednesday than this. Madalena, thanks again. And we'll see you hopefully tomorrow. I think Promise and Robbie are discussing a case. I personally can't wait. See you all. Thanks.
Bye, everyone.